Good evening. Thank you all for coming. I'm Donna Boynton, the Public Relations and Community Education Coordinator here at Milford Regional Medical Center. We are very fortunate to have with us tonight Dr. Michael Vazquez. Dr. Vazquez is an orthopedic specialist, and he's with Mulroy Orthopedic Surgery and Sports Medicine here in Milford, where he has been since 2009. Prior to joining us here in Milford, Dr. Vazquez worked with some pro sports teams, assisting team physicians for the New York Jets and New York Islanders. So we're fortunate to have him with us this evening, and here at Milford as well. So he'll be discussing shoulder pain and causes, treatments, various options. If you have any questions, feel free to ask him as we go along. But please enjoy this evening. And now, Dr. Vazquez, thank you so much.
Thank you. Thanks. Thanks for coming out on this night. I know the weather could be a lot better. Thanks for making it. Although I did help out with the New York sports teams, I was born and raised in Massachusetts, and I am a fan of all the Massachusetts teams. Okay, just to get that out there. Yeah. So before I start, I brought a bag of different kinds of equipment that we use. So I'm just going to have you pass it around just over the course of the talk. You'll see me show these, and just so you can get your hands on them, take a look, and if you have questions about them too. Even if you don't know what it is yet, you can check it out, and we'll talk about it. We'll talk about it later. Yep. These are some anchors. Here's a shoulder replacement you can start off with. Yeah. Let's see, we got some other stuff in here too. Here, we have a plate and screws for you, sir. Yeah. Here's a little cannula. This is used for shoulder surgery. And here's another prosthesis that is falling apart, but it's got multiple pieces, so you can pass that around. All right. All right, so let's get started. In this talk, I'm going to try and talk at first in general about the anatomy of the shoulder, looking at kind of the basics of the shoulder anatomy, also looking at some basic definitions when we talk about tendons, muscles, ligaments, cartilage, those structures that make up the shoulder. Then I'll talk a little bit about my evaluation of shoulder pain, and then go through a bunch of common shoulder problems that I see. All right. So the real basics of the shoulder anatomy, you have basically made up of three bones: the humerus, the scapula bone. The scapula is what also makes up the socket, which is called the glenoid, and then the clavicle. They all come together to create the whole shoulder motion and stability and strength of the shoulder. So all three of these bones are important. We tend to focus a little more on the ball and socket joint when we say shoulder, but there's really where the collarbone meets the scapula here, called the acromion. That's also a joint that can be injured and cause pain. And again, if there's questions as we go along, you can feel free to ask those. I show this picture here. This is the deltoid muscle here. So this just shows with your right under your skin, there's basically this muscle here that covers the entire shoulder. So this comes into play when we think about surgeries and how do we actually get to the shoulder joint. If you're going to try and get there with an open surgery, you've got a lot of muscle that you need to move out of the way, and that's one of the benefits of arthroscopic surgery, is minimizing the trauma to the other tendons and muscles that you are not necessarily trying to fix, but trying to avoid injuring. All right. I put this picture up there. This is a little more detailed picture of the shoulder. It's got here's the humerus bone again. It's got some tendons drawn in. But in particular, to show this word here, the bursa sac. So there are bursa sacs all over the body, and I've got another slide about that. But in particular, in the shoulder, there's a bursa sac that's underneath this edge of bone called the acromion, and above the rotator cuff here. And in this diagram, it's showing a rotator cuff tear. But here, this bursa sac is an area that can get quite inflamed and is a very common source of shoulder pain. So some definitions, some people will come in to see me and I'll say, oh, you broke your shoulder, and they say, no, they called it a fracture. Well, those mean the same things. If the bone is broken, it's fractured. We just use different words as orthopedists or as physicians to describe the break, such as angulation or displacement, how far away the pieces are from each other. Another word, comminution, is when there's a bunch of little pieces. So a break is a fracture, same thing. The ligaments, they connect bone to bone, and they're around joints. They help stabilize the joints. This is a pretty busy slide, but really what I wanted to show is that this is the ball and socket joint underneath these ligaments. All these ligaments basically surround the whole shoulder. When the shoulder goes to the extremes of motion, those ligaments stretch or tighten to hold the shoulder in place. And when the shoulder dislocates, those ligaments are typically injured, whether they're stretched and torn themselves or where they attach are torn. And tendons connect muscles to bones. So here in this picture, this is one of the rotator cuff muscles, and it turns into a tendon, which then turns to the bone. So the tendon is only as good as this muscle is, and the muscle is only as good as the tendon. One without the other is not very helpful. And around the shoulder, the major tendons that tend to cause pain are the rotator cuff and this biceps tendon here that runs right in front of the shoulder. So also looking at the joint, this is true of most joints of the body. There's lined by hyaline cartilage, specific kind of cartilage that's low friction, and in the shoulder it's called the glenoid, and the humeral head. That portion, it's basically a ball and socket type joint. We'll get to that. There's another kind of cartilage inside the shoulder. So when people say, oh, damaged cartilage in my shoulder, oftentimes they're referring to this cartilage called the labrum. And it's a different kind of cartilage that goes around the rim of the socket. So here, this is a picture of the socket with the ball removed. So you're just seeing the whole socket, and this rim of cartilage there, called the labrum, is another structure that can be injured, but its main function is to deepen the socket to help stabilize the shoulder. All right. Back to the bursa sacs here again. This area right here is the main bursa sac in the shoulder that seems to get inflamed. We'll talk some more about that later. Itis, anything that has itis connected to it means it's inflamed, painful. Arthritis, which can also mean just wearing down of the cartilage, but we talk about pain associated with the wearing down of cartilage and inflammation. Tendonitis, obviously the tendon, and bursitis. All right, so when I have a patient that comes in to see me, there's three basic things on every visit that I'll look at to typically get the diagnosis and start helping the patient, treat their pain or whatever problem they're in for. So first is the history, just talking to the patient. Most of the time you can get a very good idea of what's going on just by getting details. And the history even starts even before they even tell me anything by looking at how old they are, what hand is dominant, what they do for work, those kind of things. Then the physical exam helps narrow it down, and x-rays are a very good test that can show a lot of different problems in the shoulder. And so let's go a little bit further into that. So again, the history starts even before I even ask any of these questions. Again, their age is important. I want to know other things like where exactly does it hurt on the shoulder. They can point to the top of the shoulder, the side, the front, back, even towards their upper back or down the arm. So that's important. And what's critically important is how did it start? Is this something that's been bothering somebody for weeks or months, but they don't remember anything that injured them? Or is it a defined fall, something that they did that they said, oh yeah, I injured my shoulder at this exact time? And that will really help me figure out what's going on. Also, what's going on with the pain as well? Is there weakness? Does somebody feel like they can't use their arm? It doesn't have the strength. Or stiffness, it just won't, they can't reach where they could, especially reaching, behind in a car. I get that a lot. Or trying to reach overhead. They feel like they don't have the motion anymore. What makes the pain worse, but also what makes it better, and then what treatments they've had. And most people, by the time they see me, they've either been seen by their primary care doctor or they've tried things on their own, taking ibuprofen or just resting it, even ice, those basic things. So a lot of people have already tried that. So I want to know what they've done and if anything's helped. And then the exam. And all my shoulder exams actually start with not the shoulder, with the neck. So I don't really get into this too much in this talk, but one of the actually somewhat common causes of shoulder pain is a pinched nerve in the neck. So I always start with the neck and start with the range of motion and to see if they have any pain around the neck. The other thing that I look at that's sort of examining the neck, but more so the nerves, are the any numbness or tingling, pain that goes all the way down to their hand that shoots from their neck. Those kind of things can help me focus a little more on the neck as opposed to the shoulder. But assuming that neck exam is normal, then I go on to the shoulder, looking at where exactly it hurts. So I'll push all around the shoulder, trying to find a specific painful spot. Look at their range of motion, the strength in the shoulder, in particular the rotator cuff, we'll talk about that some more. And then there are specific tests that I'll do if I'm narrowing it down to what I think the problem is and do those specific tests. And what also is very important is examining the other shoulder. And most people have at least one good shoulder, although that's not always the case. But as long as there's one good one, I know what their normal should be. And that gives me a good idea as to what's going on with the one that's bothering them. And then x-rays. I'm going to run through a bunch of slides here, not because I want you to memorize all these or you're going to remember all these, but more because when I have patients, particularly that come in my office, a lot of them don't want to get x-rays. They say, why do I need that? That's not going to show anything. It's a waste of time. And it's actually very, very important in the initial evaluation. So anyone that comes in with shoulder pain gets an x-ray in my office unless there's some extenuating circumstance where they can't get it or won't get it. And you can see all these things, this whole list of things. So I'll just quickly go through. So the picture on the left is a normal shoulder. And here's the socket here, and here's the ball. Here is the acromion and then into the clavicle here. And, you can see that this ball doesn't quite look like this one. There's a break that goes right through here, and it's tilted down. Something that's easily seen on x-ray. Probably someone's going to tell me that they fell and it really hurts and it's swollen, so I'll have a pretty good idea that's what I'm looking for, but this x-ray really makes that diagnosis. Here's the same kind of idea, clavicle fracture. Here on this side is the normal clavicle. And on this side, you see that it stops here and restarts down here. Well, that's pretty obvious too, and that's even when examining someone even more obvious than the shoulder or proximal humerus fracture that I showed previously, because this, as you can see here, can be really pushing up on the skin and something that you can feel, or the patient will feel and say, yeah, this is broken. I can feel it crunching around. But the X-rays again show it definitively. Here's another one. Here's the normal. Anyone see what's wrong with this? Yeah, it's dislocated. So here's the cup, and now here's the ball sitting in the armpit. And so again, from the history and exam, you have an idea that's what happened, but this shows you definitively. This X-ray is a little more subtle. So this is showing a shoulder separation. So that's kind of the common term for it. It's really an AC joint dislocation. So where the end of the collarbone here meets the acromion, this should line up like it does on this side. See this side? Here's the end of the collarbone. Here's the acromion. That's the joint. So here, this is out of place. And if you really look at it, it says with weight. So in this particular X-ray, the patient is holding weights in both arms to accentuate this injury. And here's a picture of arthritis in the ball and socket joint. We call it the glenohumeral joint. So here you can see between the socket and the ball, there's actually a little space there. That space is not really a space. It's actually cartilage. cartilage doesn't show up on X-ray. So when we look at X-rays, we can infer what the cartilage looks like by how much space there is at the joint. And now if you look over at this other X-ray and you look at the socket and the ball, you can see that maybe there's a very slight small space there. But that's arthritis, where that cartilage is worn down to where the joint space is narrowed. The other ways I know that there's arthritis here is right here that I'm outlining with the cursor. This is a bone spur. And bone spurs are a product of arthritis. That's around joints that get arthritis, you'll get bone spurs. So it's not that the bone spur is necessarily the problem here, it's a sign of the problem. Again, on X-ray. You don't need an MRI to show that. You don't need an MRI to find out you have arthritis. Here is a picture of the clavicle and the acromion. Here's the AC joint, and this arrow is showing that there's a space between the end of the collarbone and the acromion. That's the normal joint. This person has pretty bad arthritis here. This is the same thing, except there's a very narrowed space and all these bone spurs on the edges. So this is arthritis of the AC joint, and a very common cause of pain. Here's another one. The normal one again is on the left. Can anyone see anything different on the one on the right? This whole big fluffy cloud right here. My cursor is kind of going crazy. Right here. This is a calcium deposit, and it's right where the rotator cuff connects to the shoulder. Now, again, you can't see a tendon on X-ray, but in this one you can because there's calcium in there. So this is a problem. If it's inflamed and it's painful, it's calcific tendonitis, a common problem that an X-ray will make that diagnosis, or help with that diagnosis, I should say. This one, I know you guys by now know what the normal one looks like, so you can tell that all these little circles here are not normal. So you can have loose pieces floating around the joint. This patient also has arthritis, and this is an arthroscopic view inside, not this shoulder, but a shoulder that has these same pieces floating around in the shoulder. So that's, again, something that you can find on X-ray. And very uncommon, but not 0%. So here's, sometimes you can pick up on a tumor. So someone that has shoulder pain, and doesn't take a radiologist to see the difference in these two proximal humeri. This one is very distorted compared to this one. Again, something that you'll pick up on X-ray. So there's my plea for when you go in and the orthopedist wants to get an X-ray and you say it's not going to show anything. It may show a lot of things. All right. Any questions about those? I'll move on to the, I'll get a little more in depth with these problems here that we'll go through. I'll spend a lot of time on this, the rotator cuff, because that is a very common source of pain and a reason why patients come in to see me. All right, so rotator cuff pain, I kind of break it up into two separate things, although there's a lot of overlap as far as what the patient feels. So in one, I'll put tendinitis, which includes, you saw the calcium that builds up. That's one of the forms of tendinitis. And that's, again, inflammation of the tendon. Impingement is a specific kind of syndrome where, with certain positions, the tendons may get pinched and accentuate the pain in the shoulder. And then the other area is rotator cuff tears, and that can be partial tears where there's fraying, or full tears where the tendon is completely off the bone. And again, this is kind of a spectrum of problems. Sometimes it's hard for me to categorize immediately where somebody is when I first see them, because the pain can be very similar in their history, and exam can be similar with these problems. All right. So here's just a list of different things that I'll look for when someone comes in that kind of leads me a little bit towards the rotator cuff. What's interesting is a lot of times the rotator cuff will refer pain to the lateral side of the shoulder. So instead of people feeling it deep in the shoulder, oftentimes they'll feel like it's on their arm. And a lot of patients come in and say, I'll say, oh, you know, how long has your shoulder hurt you? And they say, no, it's not my shoulder, it's my arm. Because that pain can oftentimes be radiating down into the upper arm, even lower on some patients. But if it goes below the elbow, then I start to get a little bit concerned that they may have a nerve issue or something that's causing pain down the whole arm. But certainly I've seen it go down into the forearm. The other thing that I really want to see is do they have loss of strength? Because the strength part is going to lead me maybe more towards a tear, which may change my treatment. see. Next, when I do an exam, again, I do the neck exam, and I don't want to minimize that because that I have quite a few patients that come in thinking it's their shoulder that ends up being a pinched nerve in their neck. But again, for this talk, I'll just focus more so on the shoulder joint itself. So look at the motion, the strength. In particular, there's a strength called external rotation of the shoulder. If you bring your arm by your side and flex your elbow to about 90, to go out like this, keeping your elbow in by your side, that is using your external rotators of your shoulder. And when there's a major tear to the rotator cuff, that'll be extremely weak, even to the point where somebody cannot resist me. And so that is a kind of a quick test to see the kind of strength that someone has of the rotator cuff. And there are other different strength tests, but that's one of the most common ones. This diagram is showing something called the Hawkins impingement test. It's just named after the surgeon that coined it. So it's basically bringing the shoulder up and turning it in like this, and that forcefully brings part of the shoulder to pinch the rotator cuff. And if you have shoulder pain coming from the rotator cuff, oftentimes this reproduces the pain, and people don't like when I do that. All right, so once again, one of the things, we already saw this, but the calcium deposits, that's one of the causes of tendonitis in the shoulder. Here, this is a little diagram showing what happens in impingement. So to try and orient yourself, this is the ball of the shoulder, and the arm is going down here. So this is a diagram of someone's arm just by their side. Here's that acromion bone. Right underneath is the bursa sac, and right below that are the tendons, some of the rotator cuff tendons. When your arm comes up into this position and in that twist position, as you can see in this nice diagram, you'll see that bursa sac get pinched between the acromion bone and the tendon, and that can reproduce the pain, cause pain. And that's one of the things that we think after repetitive reaching overhead, that's one of the risk factors for developing some bursitis or tendonitis in that shoulder, rotator cuff. So let's see. So what do we do about rotator cuff tendonitis? Now this is grouping in the tendonitis impingement standpoint, where I don't think that there's a rotator cuff tear. Well, certainly the term activity modification is just one that we use all the time. It depends on what causes the pain. Is it something that's very specific that someone can avoid? Well, if that's the case, most people don't end up coming to see you. If it's something that, you just have to say, well, stop doing that. So usually that's something that someone's already tried, and either the positions that bother them are not something they can avoid, that's just day-to-day life, or it's something with work. But most people will try to avoid the things that bother it already. Medications, those two that I listed are non-steroidal anti-inflammatories, and I'll take this time to just talk a little bit about them. It's a very common medication that we will give. They're anti-inflammatory medications meant to get the inflammation down. So it doesn't specifically target one particular diagnosis. So anything that causes inflammation, this should improve. The things I always tell my patients are, you got to be careful with taking this medication as far as the potential for stomach ulcers, potential for damage to kidneys. And so this medication, while it's over the counter and overall a safe medication done in short periods, any prolonged use, I really like my patients to discuss that with their primary care doctor as far as what their other problems are and how it interacts with their other medications, because they can cause significant side effects. All right. So I'll keep mentioning those. Just remember that part that I just told you. All right. So the physical therapy will do that a lot to strengthen the tendons, to strengthen the muscles around the shoulder, not just the rotator cuff, but the big muscles in the back of the shoulder that stabilize the scapula bone. And those can be shown, the physical therapy has been shown to improve the pain caused by impingement or tendonitis. So that's certainly a good treatment. The things that I can do in my office, or one of the things I can do, is a cortisone injection. And a cortisone injection is targeted to the area of the shoulder or whatever part of the body that has the inflammation. And the upsides of that is that it can be really localized to that area, so you tend to avoid the systemic effects of medications that you take by mouth. In this case, where the tendonitis, it's in a specific spot you see on that diagram. The one on the left, that's basically how I do my injections, from the back underneath the acromion bone to get the needle into that bursa sac to deliver the numbing medicine as well as the cortisone itself. This impingement test I wrote about is that I put down here is also a useful test that has to do with the injection. So if someone's having a lot of pain in that shoulder, and maybe I'm not sure exactly where it's coming from, but I think it may be from the this bursa sac. I can give this injection, and with the numbing medicine in there, several minutes later they'll actually have a good effect if that's where the pain is coming from. And then I'll do those same things, and they'll say, "Oh yeah, that doesn't hurt anymore." So I can numb up that area, and so if that occurs, then I know that's certainly the area that's bothering them, and I don't have to worry about as much about a pinched nerve or something in another part of the shoulder that's causing the pain. So it's a good test for me in the office to confirm that diagnosis. The cortisone can take several days, even a week or 2 weeks, to really have its full effect. Overall is low risk. Again, when my patients, I'll tell them there's a very small risk of infection, small risk of bleeding. The needle is going through some tissue, so if you hit a little blood vessel, you can get some localized bleeding. If someone's on a blood thinner, I definitely make note of that, and they're at higher risk. Question? Yeah, so the question is, can you go through a cortisone injection more than once? Yes, I'll say in general, yes, but it also depends on, in my practice, what body part, what the cortisone is for, and what the, what was the response to it. Certainly for something, if I'm suspecting this problem, tendinitis or bursitis, impingement, all these things that I'm kind of categorizing as similar, yes, it's not atypical for someone to get an injection, feel like, hey, that helped, but a few months later they come back and they say, I think it's wearing off, it's getting worse again. I will certainly give them the option to have another cortisone injection. 2, even 3 cortisone injections over several months or a year. I don't worry about the cortisone wearing down the joint or the tendons at that amount. If you start going more than that, well, that's a consideration. And then you take other things into account, like what are the patient's alternatives, So someone who's, let's say 100 years old that is very sick in other ways, but just has terrible shoulder pain, they're not going to have surgery or anything else done. I'll give them cortisone injections kind of over and over every 3 months if they need it, because the downside is low compared to, what else we have to offer. So it varies patient to patient, but in general, yes. Good question. All right. So if all those things that we talked about fail, and another question. Mm-hmm. So it's a good question. Yes, it is. To some extent, it's systemic. What the kind of steroid I use, it's called Depomedrol is the brand name. It's methylprednisolone. There are different kinds of steroids, but this is it's a suspension, so it's basically meant to slowly dissolve in the area. But as it dissolves, it gets metabolized systemically. So that's the other thing I'll tell patients, specifically who have diabetes. They may notice that their blood sugars go up a little bit for a short period of time because of the cortisone injection. But compared to like a pill, the systemic effects are minimal compared to oral steroids. If those things that I listed for treatment, if those don't work and someone's having significant pain, and we can go to a surgery, and certainly that's less common for this problem. Unless there's a tear in the rotator cuff, which I'm going to get into, it's much less common for someone to end up with a surgery if it's just tendinitis or bursitis. We usually can get that under control. I'll show you a picture of the calcium. Sometimes when someone has a big buildup of the calcium, they get recurrent shoulder pain, and even though they respond to the cortisone, it comes back, and they get tired of dealing with it. So to treat this problem, it's an arthroscopic surgery, and you can read that as easy as I can say it. But there's the instrumentation is about the size of a pen, so they're small incisions and minimizes the collateral damage to the shoulder. I think passing around right now is one of these little cannulas right here, and that's a little port that we put into the shoulder so that we can easily bring in and out the instruments. It's a green little it looks just like this. So when that comes around, you can check that out. We use that quite a bit for arthroscopic surgeries in the shoulder. So what are we doing there? Well, I pointed to you over and over again where that bursa sac gets pinched between the bone and the rotator cuff. Well, here's an arthroscopic view of that acromion bone right here. So what you can't see is below here would be the rotator cuff tendon. You can see it in this picture. It's right here, but in this one it's just not in the view. And so this is people's normal anatomy can have a little bit of a slope or a hook to the end of the acromion bone, or it can be a bone spur. But what we do is, and I don't know, I think I may not have brought it, but there's a burr right here. This is this metal instrument that goes in through one of those portals, and we can burr this bone to flatten it out, and you can see the room now between the rotator cuff and this bone. And so when someone goes up into those positions, now there's more space there, essentially minimizing that impingement. So this is a treatment for that. And again, I think it's less and less we'll do that now because the non-surgical treatment really works well, but some people still end up with this surgery. So I showed you those pictures of the calcium deposits. So I have a lot of patients who have tendonitis from the calcium deposits who will respond initially to the cortisone, and even to physical therapy, but it comes back over and over, and we decide that it's best to treat this with an arthroscopic surgery. And as you can see on the diagram on the left, it's showing that the calcium is actually within the tendon itself. So when we do the surgery, we actually have to do a little bit of collateral damage by opening up the tendon typically. And the picture on the right, this is the rotator cuff tissue all around here. And this right here is the calcium. This is abnormal. It should kind of look like the rest over here. But this instrument has opened it up, and it comes out. Sometimes it's even like a toothpaste. It's and we have shavers that will go in and kind of remove that calcium. Question. Don't know. We don't. You know, so what's interesting about this problem is that when someone has this problem and it's been bothering them for 2 months, the calcium has been there for longer than 2 months. Because also when they're feeling better after a cortisone injection and all the inflammation around the tendon is gone, then even though the calcium deposits are still there, they don't have any pain, and we don't need to bother doing anything about it. Now, I have seen patients who have come back and they've had less calcium deposited on the x-ray. So the x-rays, I'll have a patient that I've seen 2 years earlier that had this problem. I see them again, get another x-ray, and they seem to have less calcium. So some of it was their body reabsorbed it. Where does it come from? Don't know. We don't know. The risk factors really for this problem are not well defined. So, and even if you do have the calcium, that doesn't mean it's actually going to hurt you. Well, so sure, you've got calcium that runs through your whole body, to a certain extent, bound in the blood to certain carrier proteins. But does it come from that? Probably, but how? Why does it all of a sudden go in that tendon? And the rotator cuff is particularly prone to it, but there are a lot of tendons in the body that can build up calcium. All right. So after this kind of surgery, usually it's just a sling for a few days, pain medication for a few days, and physical therapy to regain the strength. And usually by 3 months, people are feeling very good, and hopefully even earlier than that. So in this specific surgery where we're just cleaning things out or shaving, there's nothing that needs to heal as far as tendons, like a repair. And I'm going to get into that next. So you can remember this slide, but by how minimal the after surgery work is compared to when the rotator cuff is repaired. All right, rotator cuff tears. All right. So rotator cuff tears, again, have similar kind of pain, but there's kind of put them into two different categories. One is where an acute tear, where usually someone will say, I fell, tried to stop myself, or I was falling, I grabbed onto something, and I felt my shoulder really hurt when that happened. They may have difficulty lifting their arm up, significant pain, or degenerative tear, where there's not one defined injury, where they feel like their shoulders hurt them off and on for a while, and in the end they'll say, hey, this is seems to be getting worse, and they may have a torn rotator cuff just from wear and tear without one particular injury. So I go about a little differently treating these two scenarios for rotator cuff tears. And again, on this diagram, it's just showing that it's literally the tendon where it inserts to the bone where it tears off. All right. I purposely have been avoiding talking about MRIs, but I can't avoid it anymore because most people come in want to have an MRI as soon as they walk in the door. And part of my talk is to try and show you that most things that people come into for, I don't need to get an MRI to tell you, what the best thing to do, or at least to start treating the problem. In this case, if I really suspect a rotator cuff tear, I do want to know about that, and I will get an MRI for suspected rotator cuff tear. Especially in particular when someone's fallen and they've had a significant injury with weakness. I want to know about that acute tear, the one that just happened. So here's a MRI. On this side it's normal, okay, and I'll try and show you a little bit. Here's the head. Here's the socket here. This right here, everything's a different shade of gray, but this darker gray here is the muscle itself of one of the rotator cuff tendons. As it comes out towards the shoulder here, it turns into a tendon, and this darker signal here is the tendon that attaches to this bone. And overall, that looks pretty normal. There might be a little brightness here, but that tendon is connected. It's a little different quality MRI, but the same idea, same kind of picture. Ball, socket, muscle here, turns into a tendon. And then when you get to here, you see that there's all this bright stuff, and then this is where it should connect to. So this tendon is torn off this bone. So that supraspinatus tendon, that's a full tear of the rotator cuff. And an MRI for me is the best thing to show this. Some ultrasounds can be done that can help show this as well, but to me the MRI gives me the most information about that rotator cuff. All right, if it's an acute tear, someone that's fallen and that's injured and they have weakness, then I tell my patients that I'd like to get this repaired, surgery. So this is one of the few things that I will not typically go through all the typical rest, ice, physical therapy, cortisone injections, because if this tendon was connected and now it's torn and they have weakness there, then that tendon's not going to heal on its own. And that really needs to be repaired to really optimize the function of the shoulder. So that's one of the cases, one of the few cases where early surgery to me is indicated and I feel is appropriate for my patients. On the other hand, this other section, which actually happens to be most patients fall into the degenerative tear. Most people who have torn rotator cuffs do not have one particular injury. It depends a lot on the size of the tear, how long it's bothered them, what else they've done to try and get this better. If it's been 2 years and they've gone through all these things and it's not better, then surgery may be appropriate for them at that point. If it's hurt them for 2 months but they haven't done anything to try and get it better, we can certainly try things to improve that pain, especially if they have good strength but it's just pain that's the issue. Okay. So this is the same exact slide that I showed, and I purposely did that because what the patient sees and what really happens in the operating room as far as the incisions and how the patient goes home in a sling is pretty much the same. But yet what I do in the shoulder can be very, very different. And so that's one of the things that when I write patients and I talk to them about surgery and what to expect with rotator cuff repairs, they say, oh, my friend had it in 2 weeks. He was out of the sling and, he said that he had a rotator cuff tear. Well, it's possible, but most likely it was the other kind of surgery where it was just shaving the bone. And so, to the lay person, that's not, I just had shoulder surgery for my rotator cuff. And it's a very big difference whether it needs to be repaired or not. So here are a couple arthroscopic photos. This is what it looks like during surgery with the little camera in there. It's This is a view from, this is the where that the humerus bone where the rotator cuff tissue here should attach. So this white stuff here is the tendon, and it should be attached right here, and I shouldn't be able to see this hole. Same thing here. This is the tendon here, and it should be put together and brought back to this bone. And so, yes, question. So this is, so the question is this a titanium rod? This is just an instrument. We call them probes, where we just want to kind of move around the tissue. I got to tell you, I'm not sure what this is made of. Oftentimes it's just stainless steel. When we put implants in, or the things that are coming around, those can be made of different materials that can, like the anchors can be made of plastics or metal. I personally don't use the metal, but that's commonly used. No, there's still titanium used in orthopedics. Yeah, we still use titanium. You're welcome. Here's another picture of kind of pictures of the repair and the process. In here, this is the bone here. There are anchors in the bone, and those are a couple of things that have gone around those. Well, they're on the orange handles, and they've got little anchors at the tip and stitches that come out. So the anchors go into the bone. The stitches are anchored into the bone now, and we pass the stitches through the tendon. As you see here, you see how the stitches pass through the tendon? Well, once it's passed through, then we tie down the knots. So here, these are the knots tied down, and it squeezes that tendon back down to the bone. Okay? And so this is what it looks like oftentimes at the end of the rotator cuff repair. And you know, a rotator cuff repair can be very different for different people. The size of the tear, how difficult it is to repair, how many anchors are used. So it's not comparing, you know, apples to apples when someone says, oh, you know, I had this surgery before in the shoulder, you know, it was you know, took one anchor to fix it. That's very different than some patients where I'll use 6 or 7 anchors to fix. And so again, it just gets lumped into, oh, I had my rotator cuff fixed. But again, really kind of, it's tempting to try and compare to other people, but just know that it's an individual thing, and everyone's got their own healing process as well. Question? Mm-hmm. You have a pretty good idea of how invasive the arthroscopic you have to go to this point before the surgery begins? Yes. Yeah, that's a good question. So the question is really looking at all the studies and examining the patient and the MRI. Do we have do we have a good idea as far as what the repair will be like, as far as how big of a repair, how difficult it is? That's the question. Yeah. And yes, we do. We have an idea, but not always, we don't always know for sure until we're in there, because the rotator cuff tendon can when it's torn, it can pull away from the bone. And if it's been pulled away from the bone for a long time, and by a distance, several centimeters, sometimes it can scar in quite a bit, and it's really hard to pull that tendon. I've had instances where on the MRI it looks like, oh, it's not too far, and it just won't pull a couple millimeters, and then it's tight. And other times I say, wow, that tendon is way far away from where it should be. This could be a problem, and I grab it and it pulls all the way back to where it belongs. So there are a lot of things to kind of give us an idea, but really we don't know till we're in there and we grab onto it to figure out the quality of the tendon and how far it moves. That's a good question. All right, so that's the repair there. These are these anchors, again, just showing that it's anchored into the bone and these stitches come through them, a bunch of different kinds. We don't have to get bogged down with that. So here's the rehab difference. So, and we oftentimes use these slings, not always. I won't get into why I use a different sling for different patients, but this is kind of a typical one you may have seen people wearing around. There's a little pillow to bump it away from the body. But we'll do that for 6 weeks. During that time, you can't drive. So that's one of the big things when someone comes in and says, you know, all right, I'll see you at the next visit. And I say, okay, who's going to take you? It's like, what do you mean? I'm just going to drive. No, you're not. You need to have this arm in the sling. You can't be using it on a day-to-day basis. It's got to rest. that, as you saw in those pictures, that the stitches are holding the tendon in place. It's got to heal. Those stitches are pretty strong, but they're not as strong as your own muscles. If someone just goes like this with under their own strength, you could pull right through those stitches. So those stitches are meant to hold the tendon down against the bone, to allow the tendon to heal back into the bone. Once the tendon's healed into the bone, you don't even need the stitches. We leave them in there because that would just cause more damage and no use to take them out, but you don't even need it after that. So these first 6 weeks are pretty critical to try and get some of that healing started before we actually at least for me, let patients really move it on their own. And it does depend on how bad the tear is, how many anchors, and those kind of things. But in general, 6 weeks in the sling. I will start therapy usually after a couple weeks after surgery. I'll have the therapist start to gently move the shoulder to try and avoid it getting really stiff, which is one of the possible complications after rotator cuff surgery is stiffness. I won't let people move their shoulder on their own till about 6 weeks when they come out of the sling. Strengthening really doesn't start for usually a few months. And it's usually 6 months before I tell my patients, go ahead, do whatever's comfortable for you. Now, I got to tell you that typically at 6 months after a big repair, patients are still not saying, oh, wow, yeah, my shoulder feels perfect. I can do anything. No, it's more of that there's enough motion, there's enough strength to do most normal things. But is it working as good as it's going to be? Probably not. I've seen people improve a year, even a year and a half after surgery, and I'll see patients come back a few years later for their knee bothering them or something else, and I'll ask them about their shoulder, and they'll say, yeah, but it took a good year or a year and a half for it really to fully feel normal. So I also tell my patients that, because I think that's important, not to be discouraged if it's still stiff or still painful after a few months or even after 6 months. As long as it's moving in the right direction, we just follow it that way. All right. Frozen shoulder. That's another very common problem I see in the office, and that's really global shoulder pain and stiffness. And we break it up into 3 different stages. Although how well defined these stages are is different for every patient. But really, what I look for is someone having significant pain and stiffness in their shoulder in all directions. And the biggest thing on this slide is the 2 years, because unfortunately it can take people up to 2 years to get over this problem. And so I spend a lot of time trying to go over that, because it can be frustrating for sure. So the question is, what is a frozen shoulder? It's like you almost knew what my next slide is. Yeah. So here, this is this is a picture, a depiction of it. On the left side is what the capsule, the joint lining around the shoulder should look like by diagram. It's just, there's no thickening, there's no inflammation, it's just ligaments that hold your shoulder. In frozen shoulder, all those ligaments around the shoulder get very inflamed and tighten up, and they stiffen up the shoulder. Why frozen shoulder happens? Again, kind of similar to calcific tendonitis, we don't know usually what happens. Some people will come in and say, it started hurting me after I did a bunch of yard work, or I was painting something and, painting the garage, and a few days later it started to hurt, and now it's just getting really bad. Most people don't remember anything. They just say, my shoulder started to hurt, it's been getting worse and getting more and more stiff, and then I worry about this problem. So this is a good description, or just a picture, and right. So the causes are not well understood, but we do know that there are certain risk factors. So one of the causes of frozen shoulder is after an injury, like if you fracture your shoulder or you damage your shoulder from an injury. If you're in a sling or immobilized for a prolonged period of time, that can certainly be a risk factor for this stiffening of the shoulder. People with diabetes, just another thing to add to the problems with diabetes, is they're more likely to get this problem. And when they do get it, it seems to be more severe and take longer to get better. The diagnosis for this is usually by history and exam. I get x-rays as well, just to make sure there's none of those other things that are going on. But usually by the end of the history and exam, I'm 95% sure that this is the problem. The treatment, kind of similar. I put here time, which is different than the other ones, because there's good evidence that even if you don't do anything, if you don't do any specific treatment, it will go away over those 2 years. So all the things that we try and do that I tell my patients is to get it to feel better faster and to improve their shoulder function quicker. But in general, this will get better just without doing anything. But 2 years is a long time to wait. Here's an arthroscopic view of, by the way, all these images are just taken off of Google. So there's, I don't know any of these patients. Okay, so this is a picture of the front of the shoulder. Just here's the ball, and here's the socket, and here's one of the rotator cuff tendons, and this just looks like normal tissue. This is the same view. Here's the ball and socket, and this is the same area, and you can see the difference. The inflamed tissue, the lining of the joint is very inflamed and thickened, and this is what happens with frozen shoulder. Let me just go back actually, because let me just quickly say that surgery is very rare for me to do surgery on this. The only times I've done surgery is when someone has gone through the phases, the first 2 phases, and they actually don't have any more pain, but their shoulder remains very stiff, and they just can't move their shoulder, and they've gone through therapy, they've worked hard at it, and they're just not getting better. Then that's when I think a surgery can be helpful to try and break up that scar tissue, the inflamed. Actually, the tissue isn't inflamed anymore; it's just really thickened tissue. To open that up and to regain some of the motion. But when the shoulder is actually painful and in that inflamed stage, I think you can actually sometimes do more harm with the surgery and cause more inflammation and pain and not do any better. So this is one of the things that, no one wants to have surgery, but a lot of people with this pain will come in looking for a solution. And I have that conversation quite a bit that surgery is not the solution for this in general. It should be really a last resort in certain circumstances. All right. How we doing? All right. Got a couple more. You guys can make it? All right. All right. So labral tears. Let's look at that. So this is the picture I showed before. The labrum is that other cartilage in there that lines the socket, adds to the stability of the shoulder. Again, usually there's 2 different ways someone will come in with an injury with this. Or a problem with the labrum is they've injured it with one particular injury, a fall. Their arm has gone really far in a direction that it shouldn't, can injure that labrum. And then there's sometimes with repetitive overhead kind of activities, especially we think of it with sports, with tennis serves or throwing a baseball, you can get more of a wearing down of the labrum or tears that aren't just like one particular event, but over time. Sometimes they can be with, or the labrum usually gets actually injured when someone dislocates their shoulder. So I showed you that picture of the shoulder out of the socket. So when the shoulder goes out of the socket, all the ligaments that were holding it in pull, and the ligaments attach right to that labrum. So instead of the ligaments tearing, usually when someone dislocates the shoulder, it tears the labrum off the bone. So this is another case where an MRI is needed. So again, X-rays are really good, but for this, an MRI. And in particular, when I have a patient I suspect this of and who's kind of failed the other kinds of treatment, as noted here, the anti-inflammatories, physical therapy, then I'll get this special kind of MRI called an arthrogram. And an arthrogram is the radiologist will put an injection into the shoulder, not to get it to feel better, but to put contrast in the shoulder to just give a better picture of the structures, in particular the labrum. Because it's a very subtle kind of finding. So this black triangle right there, this is the tear because of that white signal at the base of it. On this side, the black triangle is there, but you see there's no white signal in between it. So this is a torn labrum. That's all it looks like on an MRI. So a lot of labral tears, especially the ones that are associated with someone's shoulder recurrently popping out or feeling like their shoulder is going to dislocate, we will do surgery to stabilize that and to fix the labrum back. This is a picture of the socket here, and there are anchors in the bone similar to the rotator cuff anchors. They're a little different design, but similar. And those are in the bone, and those stitches are wrapped around the labrum, pulling the labrum back down to the bone where it came from. So on that MRI where that little white blip was, that would be squeezed down to allow the labrum to heal right back to where it belongs. All right, arthritis. So I mentioned before there are two different joints really in the shoulder, the ball and socket or the glenohumeral joint, and then the acromioclavicular joint, the AC joint. So let me just start off with the AC joint. This is a picture of arthritis at the AC joint. See, it's even telling you Google where. And so that's narrowing of the joint, and that's a very typical place where patients can have pain. And arthritis is one of those problems that can be there for a long time by x-ray, but not cause symptoms. So when someone like this comes in with an x-ray that looks like this and says that their shoulders hurt them for 2 months, this arthritis has been there for a long, long time. And so that's one of the questions I often get is, well, why is it hurting now? Can't always answer it, but sometimes it has to do with some change in activity they've been doing. If they've somehow irritated, even sometimes with a minor trauma, you can irritate the arthritic joint and it can stay inflamed. So if it were a normal joint, it would just shrug it off, but when it's got arthritis, it stays painful. So I have a lot of patients that come in that have that story. Usually 40 to 60 years old, but I got to tell you, I've got patients that are in their 20s that are weightlifters, that wear down this joint at a very early age and that need treatment for it. So I showed this so the typical things that you see the theme of what we can do when you come to the orthopedist. You know, the cortisone injection, the reason why I put this again here is because it's in a different spot now. So that's one of the things that's really important when treating shoulder problems with a cortisone injection. It's not just, oh, let me get an injection in the shoulder. It's not just a blind, stab in the side of the shoulder. It's very specific to what the problem is. And in this case, for the AC joint, I don't draw it out, but in my mind's eye, I see where the anatomy is. I push on where it hurts, and I find that joint, and the needle goes right into that joint. And I would expect that to get the symptoms better. So the numbing medicine, once I put that in, 10 minutes later, if that's where the pain was, people will say, oh yeah, that already feels better. And so then I know that I'm in the right place. If they don't feel it's better in 10 minutes, then I'm concerned either I didn't get it in the right place or it's the wrong diagnosis, that there's something else that's bothering them. So we do all those first 3 things over and over, and some people do end up with surgery. And again, this kind of surgery is really a patient decision. It really depends on how much treatment, how bad it hurts you, what it limits you doing. That's it. So that person with that x-ray may never need surgery, and hopefully doesn't. But someone with an x-ray that looks, mild compared to that may need surgery because of their symptoms. Yes? So the question is rotator cuff tendonitis diagnosis since January, and how's it going to get better if we keep moving the shoulder? Yeah. So it's a good question, because certainly that's one of those things that we talk about, activity modification, trying to minimize or avoid the things that bother it. So certainly it may be something that if you keep doing overhead things or certain positions that irritate it, you can keep it inflamed, that's for sure. But on the flip side of that, I certainly wouldn't recommend that you go in a sling for something like this because of the risk of frozen shoulder, and really that's something that if you're going to be in a sling, you may find it feels better for those few days, and then as you come out, it bothers you. So with rotator cuff tendonitis, again, I would probably say that if over the next, over the few months, if it doesn't get better, then certainly a cortisone injection, focused physical therapy can be helpful. And then usually if that time goes by and it's not better or to your liking, then I get the MRI to see. You can call me, that's fine. We'd get an MRI to take a look if there's any tears in the rotator cuff. Because I do think that oftentimes shoulder pain that's from tendonitis that lasts a long time, and I'm talking about more than a few months. In the realm of shoulder pain, that's not a real long time, but that's chronic and recurring. A lot of times I do think that there's partial tearing or maybe even tear to the rotator cuff. You're welcome. All right. So here's just a if it does come to surgery, it's a simple as far as the concept of surgery. It's just we take a burr and we remove the end of the collarbone. So instead of the bone pushing against the bone, we make a space by removing the end of the collarbone. And in between that, so here in this top picture, it's showing the end of the clavicle here and the acromion here. And here it shows it removed. And then after surgery, scar tissue kind of fills in that area, but it's no longer the arthritic ends of the bones hitting anymore. There's more of a space or soft tissue there. Question? Yes, typically I'll do it arthroscopically. You can do it with a little open incision as well. But yes, it's the instrumentation, the burr is something that fits right into one of those little portals, and with the camera we can just watch it and burr away the end of that bone, and yep. Question?
I have had the very successful.
So the question is, she's had multiple rotator cuff surgeries and was last told that you probably would need a shoulder replacement, or that would be an option for you, and how successful are the shoulder replacements. Good question. That's a pretty detailed kind of answer, but in general, yes, the shoulder replacements work very well. You must have arthritis in the shoulder, I'm guessing. I don't really get into this in this talk, but for patients who have torn rotator cuffs and arthritis, there's a different kind of shoulder replacement called a reverse shoulder replacement that patients seem to do very well with. So that may be something you're a candidate for. But I would also say, without really knowing much about it, it's still based on how you feel your shoulder is, how much it hurts you, how much it bothers you, and you weigh that with the risk of surgery. That's what we always have to do. And the patient is usually the best at figuring out how much it hurts, and then the doctor can tell you about the risks, and you can balance that. All right. All right. So here's the ball and socket joint, shoulder arthritis. And this list on the side are different causes for arthritis. Arthritis is a term that we hear all the time, and I oftentimes get questions on how do you know what kind of arthritis this is? Is this rheumatoid arthritis? And sometimes we don't know for sure, but often the most common is osteoarthritis, what we just call the wear and tear arthritis. These other causes are possibilities, and certainly there's things within someone's history. When I examine them, their x-rays or MRI, that can help me differentiate a little bit. But in general, it's osteoarthritis that's the issue with patients. Okay, and so here once again you can see that there's very minimal joint between the two. So here's an arthroscopic view of a normal looking shoulder. You see this, it looks yellowish, but it's smooth cartilage. Here's the socket, here's the ball. And on this one, you can see that there's a little bit of flakes of cartilage holding on, but this is bone. This might be similar to what this is not the same person, but this is what it might look like. This X-ray with this kind of view inside arthroscopically. So in general, for significant arthritis in the shoulder, arthroscopic surgery is not a great option typically, unless there's something floating around that's getting stuck in the shoulder and someone says, yeah, it hurts, but what's really bad is every, once in a while there'd be a really searing pain and feels like my shoulder is locked. Well, that may be a loose piece going in, and that is a good reason to just go in arthroscopically and pluck out that loose piece. That doesn't cure the arthritis though, and they have to, patients need to be aware of that. To treat the arthritis pain, you're really talking about a shoulder replacement. That was the one model that I sent around, that you replace both the head and the socket. And it's usually a plastic type socket with a metal head, and you can see there's a stem that fixes the head to the bone. And that, you're literally cutting out the arthritis and replacing it with metal and plastic. All right, almost done. One last one, fractures. All right, so fractures are typically easier to figure out because someone will say that there's some trauma, and then the x-rays will typically show the fracture. Once in a while, there will be fractures that you can't see on x-ray, and that will get either a CAT scan or an MRI, but that's pretty rare. Most of the times they show up on x-rays, okay? Most shoulder fractures can be treated without surgery, okay? And so that really means a sling for a few weeks usually. After that, we usually start getting the shoulder moving so it doesn't get really stiff. But that's certainly one of the problems with treating a shoulder fracture is stiffness. And it takes time for it to heal. It takes time. So the bone heals, but we don't want it to get too stiff during that time. Now, there's definitely certain times where the bones are really out of place or angulated or in so many little pieces that we don't think it's gonna heal up properly, and we'll either fix it with plate and screws. And I sent around one of the plates, and this is what it looks like on the X-ray. That's essentially the same plate that I sent, and it's got all these screws in the head. So the break was probably right across here, and you got screws in the head, screws in the shaft that are holding that break together, and then your body needs to heal it. And here's just a diagram of what that looks like. Now, if the bone is really badly broken, we will also replace the shoulder as well sometimes for a bad break, and that would be treatment. But again, most fractures don't need surgery, but if they do, this is how we'll approach it. All right. So just to conclude, most causes of shoulder pain, I have a very good idea after the history, physical exam, and X-ray. So most of the time, I'll have a good idea of what's going on and what are the options to get my patients better. MRI is very good when I need to. Question. Yeah, good question. The question is when someone comes in for a shoulder appointment, does it make a difference if they've had the X-ray days in advance or just at the time of the appointment? And for me, there's no difference, because I'll tell you that I don't look at those X-rays until the patient is there. So to me, whether it's been done a few days before, a week before, or right before the appointment, doesn't matter. And so whatever is kind of convenient. You know, if someone's had it done, then they don't have to wait in the office to get that done as well. But we certainly do that quite a bit. Yes. So that's a great question, and that would be a topic for a bunch of orthopedic surgeons talking about how to fix this break. So that's like a high level question. But osteoporosis is a big problem, and it's a big problem in the shoulder because the shoulder's not a weight-bearing joint. So no one walks around on their arms. So that's one of the spots in your body that is very affected by osteoporosis. So it's very common that the ball of the shoulder is basically a shell that's almost hollow inside. And so that's one of the design changes over the past, I don't know, maybe about 15 years ago, somewhere around that time. This is a locking plate, so it tries to mitigate the fact that the bone is really thin. So the old plates, the screws would just compress the plate against the bone. In this kind of plate, if you see it, the screws actually screw into the plate. And long story short is that really enhances the fixation, the strength of the plate interacting with the bone. With severely osteoporotic bone, this can fail. So the screws can all pull out, the bone can move back to where it was, and that certainly can be an issue. That's one of the reasons why sometimes we'll just replace the shoulder when we feel like the bone is so thin and is going to be really hard to hold in place. But certainly these newer plates, and new, again, 15 years or so, really try to avoid that complication. But it's still a problem. It's a good question. So the question is, does that metal affect anything in your body over time sitting there? No, not really. So that metal usually sits there without a problem. Metal, when we put in metal for orthopedic reasons, such as broken bones, sometimes we take them out, but we usually take them out because it's specifically bothering the patient. And we'll see that more so when we fix bones that are right under the skin, like at the tip of the elbow or over the ankle bone. So we plan on usually just leaving them in, but after the fracture is healed, sometimes, especially in the elbow, someone will say, I bump it and it really hurts right at the edge of the plate. And so we'll go in and remove the plate, but not because we're worried that that metal is going to do a problem, have any problems. It's a little bit different because the metal is not actually in the joint. So it's kind of hard to explain, but there's no metal in the joint. So, in those arthroscopic, the views inside the shoulder, you would never see any metal there. It's all just within the bone and the outside of the bone. which is a little different when you talk about joint replacements, people who get hip replacements or shoulder replacements. That metal's in the socket, which is still, it's still okay, but sure. So the question is, she had titanium rod placed in the shoulder, and her physician said, we don't know what the effects will be. I think that's also safe to say that, is there something that's going to come out that we don't know about? That's possible, but we do, we think it's safe enough that we don't routinely take out the hardware. Good question. All right. So anyways, once again, to finish up, I think one of the a good resource, I think, for patients is this website here. It's the Academy of Orthopedic Surgeons, and they've got a whole list they separate it by body part and all these different problems, and they'll have generic ones like shoulder pain that kind of get you started, and then if you have a specific diagnosis. I just think that, on the web you can find a lot of different things if you Google stuff, and so I think if you want to try and narrow it down to really respected source, this would be the website that I would recommend. So the question is, how does a shoulder replacement compare to a knee and hip replacement? Well, again, the big difference is that you don't walk on your arms. So right away, people are just much more mobile. Typically, you are in a sling to protect it because there is a certain amount of soft tissue that needs to heal. Because to do a replacement, usually you have to remove or detach part of the rotator cuff and then reattach it. That's not always the case, but in most of them we do that, and so that still needs time to heal. But we're talking about much more functional of a time period. That the time to complete kind of resolution of symptoms is still quite a bit of time. I would tell somebody, still at 6 months, I would expect someone to be very functional and feel good about their shoulder, but certainly expect that they'll probably gain more motion and more strength with more time. Question? Good question. So on some of those other problems besides the arthritis and fractures where we showed the metal implants, are there other conditions where arthroscopic surgery is not sufficient and that open surgery is needed? Yes, there are, and they're pretty specific kind of problems. We really can deal with most things arthroscopically. The kind of situations that come to my mind where I will open up the shoulder is in cases where the very specific kind of rotator cuff tears, which are not as common, where the tendon in the front is torn off and it's isolated to that tendon. I'll make a small incision in the front of the shoulder. It's just easier for me to do it that way. You certainly can still do that one arthroscopically. The other way is if someone is dislocating their shoulder and you've tried to repair that arthroscopically, that's where there's evidence where if you do an open surgery and do things a little differently through the open incision, you may be able to better stabilize that shoulder. So that would be the other main case where it would open up. But for the most part, most of those problems would be arthroscopically dealt with. Question? So the question is, when burring out the shoulder bone, take it off the AC joint. But you mean removing the end of the collarbone? That slide? Yeah. Yeah. So the burr literally just burrs away at that bone and removes usually I'll remove about 8 to 10 millimeters or almost a centimeter of bone from the end of the collarbone. And the way the burr works, it burrs it away, so it's not like sawing a little chunk of bone off, which if you did it with an open surgery, you might just use a saw and just saw a little block of bone. But with the arthroscopic surgery, I burr it away and then there's a space there. So I don't know if I answered your question or does that make sense? Oh, okay, I'm sorry. Sure. So, right, the AC joint, it's a joint, and but when there's arthritis, it's those two bones that make up the joint are usually, they've lost their cartilage and are rubbing against each other, okay? So really, when I'm not removing the joint per se, I'm actually in a way creating a new joint. without the added cartilage, but that's done by removing the end of the collarbone, so now there's a space. So now there's sort of like a new joint there, but there's no cartilage lining it, so it just fills in with scar tissue. So, yeah, so that usually gets rid of the pain. Question? I was hoping. What about prevention? I was hoping no one would bring that up. No, I'm just kidding. No, because I was looking at the topic and we talked about prevention. Well, a lot of these shoulder problems, as far as a lot of them come from injuries, kind of freak accidents or falls, and especially the fractures. A lot of them are wear and tear, over time. So it's hard to prevent those things. What I tell people is, as far as prevention from your shoulder, is I tell anyone who's interested in working out, I tell them in general, I would keep everything below shoulder height. Even if your shoulder's normal, you can do presses over there, but you're asking for a little more problems with things over your shoulder level of height. You can certainly get a really good workout in for your shoulder, for your chest, your back, keeping everything low. So as far as prevention from hurting your shoulder doing exercise, that would be one of the things. Also, I'd say to avoid any of the Tough Mudder races. Have you ever heard of those things? So there are these races, or Spartan races, or all these kind of things where people will run and then do a bunch of obstacle courses. I have many people that come in injuring their shoulders on the obstacle courses. So that's a very specific thing. But I guess my message is to avoid the potential for injury by putting yourself into that position. Also on that website, they do go through exercises that you can do for the shoulder to specifically strengthen the rotator cuff and the muscles around the shoulder, try and keep the motion. And I think that is something that, for a lot of my patients that have these chronic problems that aren't going away, like the arthritis, doing those things on a continuous basis can make a big difference. A lot of people with really bad shoulder arthritis never have a shoulder replacement. Maybe part of it because, once again, you can kind of rest your shoulder instead of your knee and hip by you're walking on that. But still, I think a lot of those patients deal with it by strengthening the muscles and preventing the pain, really. Go ahead. Yeah. I was going to say, so the question is, I've been doing exercises, but it still hurts quite a bit for the shoulder. Yeah, I mean, that would be and you mentioned cortisone. That certainly would be an option for sure, because then that may get the inflammation better, allow you to do the exercises. So that's a good point, actually. That's a common thing when people come in to see me. And I try not to push cortisone because, in the end, it's an anti-inflammatory. I think it can work quite a bit. But if the patient doesn't feel like the pain is bad enough to have a needle stuck in their shoulder, well, then they don't need to have it done. So, but someone like yourself who's been through the exercises, it hurts them, that may be a good reason to get it done so that you can do the exercises. Question? Good question. So the question is, are there different strengths of cortisone? I can just really tell you about the cortisone that I use. It's the brand name is Depomedrol, and they're all similar in that they're derivatives of a natural cortisone that you have in your body, but they make slight differences as far as certainly as far as how strong they are, but how the one I use compares to another one, I'm not sure. The one I use comes in different doses of 20, 40, or 80 milligrams, and so certainly that I can control a little bit of how much I put to the shoulder or whatever joint. My typical is to use 40 milligrams. That just seems to work well. I did see a study that showed no difference between the 40 or 80 milligrams as far as the patient response. So I don't tend to use the 80, just to double it for double's sake. Yep. Sure. You want me to expound on that a little bit? So the question is, I mentioned how pain coming from the neck can affect the shoulder, or problems with the neck can affect the shoulder. So the times I see that are the nerves that go to your arm, start in your neck, and they travel down, they come out of your spine in certain nerves called nerve roots. C5, C6. Those are names of the different nerves that come out. And they go to specific parts of your arm. And in particular, there's a nerve root called the C5 nerve root that gives sensation to the outside part of the arm, which is a very common place, as if you remember, that people who have rotator cuff problems will feel pain here. And they can have a pinched nerve even without having neck pain. So I've had patients without an ounce of neck pain who have ended up having a pinched nerve causing the shoulder pain. The ways that I try and differentiate that is that typically where the shoulder is doesn't affect the pain. So that's part of the history in the exam. Doesn't matter if the shoulder's here, here, down here, it feels the same. Unlike when it's a problem with the shoulder, I can usually find certain positions that bother it, okay? The other thing is they may have a slight numbness or weakness in the nerves that supply the muscles. So one of them is the biceps muscle. So I might test their strength, and if they have weakness in that muscle, then I'm also really concerned about the possible nerve being pinched. I'll get x-rays of the neck, because that's a very good test to look to see if there's arthritis in the neck. But to really show if a nerve is being pinched, I typically get an MRI of the neck, and that should definitively show if there is a nerve being pinched. In that case, I usually hand you off to another physician that treats that problem. Question? Mm-hmm. So the question is, if you don't want to take oral anti-inflammatory, is there a cream you can take instead? Yes, they do have topical anti-inflammatories. There's the generic name of it is diclofenac, and I'm blanking on the brand name, but it's Voltaren. Voltaren gel. It's a prescription gel, though. It's a prescription, and it has an anti-inflammatory the same as you would take orally, because there's an oral version of that. So it's like an ibuprofen, but it's in a gel. A couple things with that. It certainly can work well in the right circumstance. It has to be absorbed through the skin. So just in my personal use, not me, but my patients, around the wrist, elbow, hands, it seems to work better to me. Around the joints that are covered by more muscle and more tissue, like the shoulder and the hip, I just find less of a benefit, maybe because it's got to be absorbed down into those layers. There still is a little bit of systemic absorption of those medications. So somebody who has a problem with bleeding ulcers, you don't want to take that, even the cream. So that's usually something people say, well, it's not going to my stomach. Well, the effects of the anti-inflammatories on your stomach are actually not from the pill directly going in the stomach. It's the way it works on the cells that coat the stomach lining to keep it safe from the acid. So long story short is that even that cream, if you have problems with stomach ulcers, you shouldn't take that either. So the effectiveness is variable. Certainly something I've tried on patients and can be helpful, but not a standard thing. It's a good question. Question? The question is, if you have a problem like arthritis, can that lead to other problems because of compensating for the arthritis? It's a good question. I don't think a well-definable, like it's not going to cause a rotator cuff tear. Certainly, can you have some inflammation around other tendons, like the biceps tendon, which that's one thing I didn't talk about, which is actually a somewhat common problem, shoulder pain. People with shoulder arthritis can have biceps tendinitis. So I guess, yes, it can be associated. I don't know if I feel like it causes it, because not everybody with arthritis will get those problems. Certainly, as the shoulder gets stiffer or any joint gets stiffer, patients try to compensate, and that's either using the other side, or when they try and reach their shoulder blade tries to do more work than it should, and they get pain around the shoulder blade. So I'm kind of giving you a mixed answer, because I think it's a little more complicated than just a yes or no. Certainly you can have other effects from it, but whether it can cause a tear or something like that in another part, probably not. Does that make sense? Question? Good question. So do I see patients that come in my office that do not necessarily have pain but have clicking? Yes, I do. I do. Usually pain is what brings people to see me, and I neglected to say this, but most people that come in, not most, but many come in because it starts to affect their sleep, and that's when people will come in. You know, they can deal with it during the day, but once they're being woken up, then it's a big issue. But as far as the clicking, can't always tell where the clicking is coming from. In a general rule that I go by is that when the clicking is not painful in something that's been around for a long time, I really don't worry about it very much. I'll do a thorough exam, you know, get more history, even get x-rays and you know, evaluate the patient. But just with that piece of information, if everything else is normal and it's just I got this click when I do this, does it hurt? No, but it's been like this for years. It's not typically beneficial to search for the exact cause. I do have a lot of clicking and catching in association with injuries or with inflammation around the shoulder, because as you saw in that picture, that bursa sac, that when your shoulder moves, if that bursa sac is inflamed, it can certainly crackle and pop and catch in there. So associated with pain, I think typically it is something. If it's not, then again, I'll do a thorough evaluation, but you know, just that piece of information is not typically going to be something that I'm going to chase after. Question? Good question. So the question is the use of ice. And, you know, it's funny that you say that because I had it like on every slide, and I was like, this is just, you know, redundant. So I probably took it off of every slide instead of leaving it on one. So, yeah, ice as a first kind of line of anti-inflammatory effect, I think is very good. Okay, the couple things I say that may sound silly is that I've actually seen a person with a very bad freezer burn and that actually needed surgery, skin graft. So don't fall asleep with a bag of ice on your shoulder or any other body part. You should have, you know, a cloth or something, you know, between the ice and your skin. But barring that, 20, 30 minutes at a time, ice the shoulder down can really help with inflammation. That's a very common thing that they'll do in physical therapy. They'll oftentimes warm the shoulder up, heating pad, warm it up, get it moving. Then at the end, do ice to cool down the inflammation. So yeah, that's it. Thanks for bringing that up. I do think that's very helpful in many cases, especially after surgery as well. Mm-hmm. Sure. The question is after cortisone, heat or ice. I recommend ice after cortisone injection to keep the inflammation down. That's one of the small potential side effects of a cortisone is some people have a cortisone flare where they'll actually have more inflammation over the next couple of days. I see that much more often in the elbow and wrist than the shoulder. Question?
Do you see any correlation between taking of a statin as a cause of joint pain?
So the question is, do I see a correlation between statins and joint pain? I've definitely had patients that have come in that have said that I've had multiple joint pains, and I was taken off the statin and it's helped. Me personally, I don't think I've made that diagnosis. That will be really something for your primary care, for sure, because they'll just be more. That's a known side effect of the statin drug, so certainly I'm aware of it as an orthopedic surgeon, but the primary care doctors, they'll see that, I think, quite a bit. So something to think about for sure if it lines up to when you started taking it. Mm-hmm. Question? The question is my opinion of glucosamine, chondroitin, and over-the-counter supplements. Usually my spiel to patients goes into I don't recommend them. There's never been a patient that's come in when I say, oh, you should try this and take this. I've had patients come in that say, oh, this works great for me. And the side effects are really minimal, except on your wallet. So I tell patients, you know, if they say, oh, this really works for me, you know, I'm not sure if it's a kind of placebo effect or if there is something that may be helping. I don't think the evidence is really there to say that it protects the joints. But if that's the case and it's worth the money and they really feel like it works, then I'm not going to tell somebody to stop. But I don't routinely at all tell someone to take it. Mm-hmm. So the question is, do I use things like visco supplementation? So like Synvisc? Is that, yeah. In the shoulder, No, actually, at this point in my practice, I really don't put it in the knees either, which is what it's FDA approved for. Just the Academy of Orthopedic Surgeons, they don't really recommend for it. The evidence for how well it works is kind of lacking. So that's not to say, once again, I've had patients that come and say, oh, it worked great for a year. Can I get another one? Usually I'll send them to get another one done. But again, for a new patient, I won't say this is what you should have. And in the shoulder, I've never done it. I know that there was certainly some trials of doing that, but it's as far as I know, it's not FDA approved at this point, and I'm not sure it will be. My most important slide, I forgot. My 3 boys and girl. Hopefully not. Well, thanks a lot for coming.